Welcome to Conversations on Healthcare. This week we welcome Dr. Anthony Fauci on the second anniversary of our first chat with him on the new epidemic just spreading around the world and what to expect next with the pandemic. Now, here are your hosts, Mark Masselli and Margaret Flinter on Conversations on Healthcare.
2 years ago at this time, Dr. Fauci joined us for a conversation that was a warning about what was ahead. We discussed what he knew about COVID-19 and how to deal with it. Dr. Fauci has continually kept us updated on Conversations on Healthcare about the pandemic.
And now Dr. Fauci joins us again to share the latest details and his perspective as the chief medical advisor to President Biden and as the longtime director of the NIH National Institute of Allergy and Infectious Diseases.
Dr. Fauci, welcome. Before we discuss COVID, let's start with the breaking news on HIV. Doctors report an American woman is now the third person ever to be cured of HIV. They used a new transplant method involving umbilical cord blood. What is your reaction to this breakthrough, and do you think it opens up the possibility of curing more people?
Well, it's going to be really, Mark, the idea of a conceptual issue that it is possible to rid the body of HIV. The only trouble is that this, as it is right now, giving a transplant of cells from the umbilical cord or a stem cell transplant or what have you, this is the third such case. As you know, the original one was the famous Berlin patient who actually, unfortunately, subsequently expired due to a recurrence of his leukemia. This is not applicable to the normal, otherwise non-diseased, outside of HIV person. This person happened to have an underlying disease which required a stem cell transplant. So I don't want people to think that now this is something that can be applied to the 36 million people who are living with HIV. This is much more of a proof of concept that one can actually get the virus out and be suppressed for a long period of time. It is not practical to think that this is something that's going to be widely available. So it's more of a proof of concept than it's something that can be applicable to the many millions of people who are living with HIV, having their virus suppressed by good antiretroviral. I want to just take this opportunity to emphasize that right now we have therapies, and we've had them for some time, that are really nothing short of spectacular in their capability of suppressing virus to below detectable level for essentially unlimited periods of time. Not only saving the life and providing a good quality of life for the people who are being treated, but also making it virtually impossible for them to transmit the virus to others through sexual contact, merely because their viral load is so low. Having said that, we are always trying to cure HIV, where you don't require either daily or intermittent therapy. And there's a lot of research going on with this. This third case, I really wouldn't characterize it, quite frankly, Mark, as a breakthrough, because we've had two other cases just like this. So we know it can happen, but as I mentioned, it's important to conceptually see this, but I don't believe it's applicable in any way to the millions of people who've actually living with HIV.
Well, Dr. Fauci, that is an incredibly important clarification for all of our listeners. I do want to stop and take a moment before I turn to COVID to thank you for your decades, 40 plus years of being so committed to ending the HIV/AIDS epidemic and caring for people who have HIV. So thank you so much for that work and the work that you continue to do today on many fronts. And I wanted to ask you, of course, about COVID. Last week, I would have told you I was sure that we'd be seeing FDA authorization of the COVID vaccine for the younger children, 6 months to 5 years old. That didn't happen. Reportedly, the data was clear about safety, but showed some disappointing effectiveness. I wonder what your thoughts are on that, what you think we will see. And I think we're all grateful that the data is transparent and clear, but do you think we're going to see approval for these little kids?
Well, that's going to really depend on what the data shows. I mean, one of the things that's important is that you say disappointment. The disappointment is that the 2 doses did not give what was desired with regard to protection in the children. It was felt that this very likely would be a 3-dose vaccination regimen for children. And that's what Pfizer is now doing. They're doing the 3-dose component on the children from 6 months to 4 years. They will have the accumulation of that data, I would imagine, reasonably soon. I don't want to get ahead of the FDA and predict when they will be able to make a determination as to whether or not it's effective. You're absolutely correct, Margaret, that it is clearly safe. Safety is not an issue here. The question is, what is the proper dose and dose regimen to give the children the degree of protection that we're aiming for? And that's exactly what's going on right now. The fact that they didn't do an EUA or an emergency use authorization for the 2-dose data is that the 2-dose data did not show that it was good enough to be able to do that. And that's the reason why they're looking at what 3 doses will do. Hopefully, 3 doses will give us the endpoint that we want. That's what we're waiting for.
Well, it's so great to hear that data is driving policy, and I think that's a comfort to everybody. We're also learning more about the new Omicron variant BA.2, and there's always reports about possibly new variants out there. How serious do these situations seem to you, Doctor?
Well, Mark, let's take one at a time and compare. We're having a lot of experience now, unfortunately, with Omicron, which is the BA.1. It is a highly transmissible virus, essentially pushed Delta off the map. However, the good news about that, if you want to call it that, is that if you look at the ratio of hospitalization to cases, that you don't have as much of a rate of hospitalization with Omicron, i.e. BA.1, than we saw with Delta. However, it does evade some of the immune protection, and that's the reason why we make a very strong push for people, A, to get vaccinated, and B, who have been vaccinated to get a boost. But to your specific question, comparing BA.2 with BA.1, they have some similarities. BA.2 is likely more transmissible than BA.1. We know that because in Denmark, it has essentially had a much, much greater percentage over a period of time in the context of Omicron. So it's kind of pushed Omicron aside. But if you look at its severity, its ability to evade vaccination protection, they are really about the same. So the only difference that we're starting to see is that one of the antibodies that worked against Omicron or BA.1, the sotrovimab, does not appear to work as well. Yet there's a new antibody that just came out right now, the data of which was just released, a Lilly antibody that looks like it's quite good against BA.2. So again, likely more transmissible, not necessarily at all more severe, and likely will start to maybe take over a little bit more. But the one good thing is that in the context of all of this, if you look at the curves of the infection cases and the hospitalizations, they're rapidly going down, not evenly throughout the country, but now virtually every state is seeing that it's starting to come down.
Great.
Well, we have been saying, dare we say some good news out there, and we've learned throughout this pandemic to be cautious about saying good news, but we'll take some good news where we see it, and that is certainly true. But right along with that good news is we also hear about other variants. We're hearing more about waning immunity with the mRNA shot protection and possibly needing that 4th dose to deal with waning immunity. What are your comments on that? Would we be looking forward to that, do you think, in the next several months as a recommendation?
Well, right now, we have to look at where we are. Where we are right now, and I think people need to understand, because when you use the word 4th dose, there is understandably some confusion. When you're talking about people who are severely immune compromised, those people really require, and it's recommended that they get a 4th dose if in fact they've had an mRNA primary series. And the reason is in those individuals, for example, transplant patients and cancer chemotherapy patients, they require 3 doses just to get up to the level of where 2 doses are for an individual who has otherwise a normal immune system. So when you say a 4th dose, they're already recommended to get a 4th dose. When you look at immunocompetent people for whom we recommend a 3rd dose, we're following very carefully, which you're correct. There is a waning and a diminution, but the latest data at about 4 or 5 months following the 3rd dose boost, it's still hanging up there around 78% protection against hospitalization. What we're following very carefully is what happens on month 6, 7, and 8. If it starts to go down to a level that's a bit concerning, then there will be a strong consideration for a recommendation of a 4th dose. But right now, today, apart from the immune compromised individuals, the protection against hospitalization looks pretty strong.
Well, thank you for that clarity. It's interesting to review at our first COVID conversation with you in February of 2020, 2 years ago. A lot of your comments then are still relevant today. You even accurately predicted a vaccine would be deployed within a year to a year and a half. What have you learned professionally from this pandemic, and anything you might do personally in a different way?
Well, you could always think of things you would do differently because no one is perfect, and everyone, particularly when you have a moving target like this extraordinarily complicated virus that acts unlike really any other virus we've dealt with. I mean, we've seen mutations and drifting of viruses like with influenza, but the idea that we would have 4 and now the 5th wave is something that is completely unprecedented. The one thing we have learned, in addition to the sobering news of the extraordinary capability of viruses to adapt to us and to escape our attempts to contain it, the positive aspect that we learned is the extraordinary positive effect of the investment in basic and clinical biomedical research. Because if we had not made that investment decades before, working, for example, with the original work we've done following the original SARS-CoV-1 in 2002, to develop the proper immunogen design, the proper platforms, that we did something. As much as this virus is unprecedented, our response with regard to the development of a vaccine is entirely unprecedented. To go from understanding and knowing the sequence of the virus on January 9th or 10th to 11 months later, have a highly effective and safe vaccine already going into the arms of individuals 11 months later, and then multiple months later, to have literally billions of doses having been distributed worldwide and over 200 million people in the United States having been fully vaccinated. That is an accomplishment the likes of which we have never seen, nor would we ever have imagined that we could have done that in such a brief period of time. So, you know, there's both aspects of it, that there's the bad news that we're dealing with a virus that has continued to, in many respects, baffle its ability to elude things. And then we have the extraordinary accomplishments of the scientific approach and the scientific enterprise.
Dr. Fauci, I'm not sure there's ever been a better case for the need for ongoing investment in biomedical research. I think we've made our case for the ages about how important it is to do that without the crisis sitting on your shoulder, so you're ready when it comes. But I have a question for you that's maybe more just historical impact. at this point, or importance at this point. But when we think back to that first conversation that we had with you, you had mentioned this is in the early weeks of the outbreak, and the Chinese were incorrectly insisting that COVID was only spread from animal to human. I guess I asked, do you think we're close to getting to the bottom of how COVID did get started, and understanding why there were so many missteps that let it wreak such havoc in our world?
Well, we want to keep a broad, open mind about what people are referring to as the origin of this. But if you talk to the people with experience, the molecular virologists, the viral phylogeneticists, the people who do this for a living, this really strongly resembles what happened with SARS-CoV-1, where you had viruses out in the animal kingdom, particularly bats interacting with intermediary hosts, with viruses that can evolve to jump species and infect humans, almost certainly. But again, always keeping an absolutely open mind that it is very likely that that is what happened. And that's the reason why it's important to continue to do research to explore the animal-human interface, to make sure that we know what's going on out there and that we're prepared for it. But one must always keep an absolutely open mind as to how this thing evolved and what happened.
You know, Dr. Fauci, Time Magazine has some good reporting about the CDC's surveillance programs and criticism that it's sequencing only a small percentage of positive cases in the single digits each week. Only about 5 countries have sequenced double-digit percentages of their positive cases so far. And should we be doing more, and would it help?
Well, the CDC has improved greatly on what they have been able to do since the very beginning, when in fact, you're right, they're sequencing themselves with collaboration of centers throughout the country was at quite a low level. But they have really made major steps, certainly over the last year, to improve on that considerably. And they're continuing to do it even better. But you're right, it's been an evolution from a lower level to now a level that we believe is a pretty good level.
And if I could just ask maybe one more question. Your colleague, Dr. Collins, who just retired as the NIH director, says it almost feels like political parties want public health efforts to fail if they're being produced by their enemies. What do you say in response to that? You've always had such a collaborative relationship with people around the country, but is that your perspective as well?
Well, I think it's no secret, Margaret, that we are now living in an environment of profound divisiveness in our country. And whenever you have something of the magnitude and impact of a global pandemic that has severely involved our country, with now, approaching 1 million deaths, with well over 930,000 deaths, we do see it, and you can't walk away from it, a degree of political divisiveness and even hostility that cannot help when you're trying as a country in a unified way to respond to an outbreak. The common enemy is the virus. We should look at this metaphorically, that we are at war with a common enemy. And when you're at war with a common enemy, it's not time, or ever should be time, of fighting with each other. We should be focusing all our efforts on containing this terribly devastating virus, which has done such destruction throughout the world, including in our own country. So I wouldn't want to put words in anybody's mouth. I'm not going to comment on what Dr. Collins said. He's a very close, dear colleague and friend. And in many respects, what I think he was trying to say, because I know Francis very well, is that he's very dismayed at the degree of divisiveness that's going on in this country, which clearly will interfere with a good comprehensive response to the pandemic itself.
Well, Dr. Fauci, it's always an honor and privilege to have you take the time to answer our questions. You can learn more about Conversations on Healthcare and sign up for our emails at chcradio.com. Again, Doctor, thank you so much for taking the time today.
My pleasure. It's always good to be with you.
All righty, great.
Thank you, Dr.
We really
Fauci.
appreciate it.
Take care.